Good afternoon, everyone. My name is Nadine Gauthier, and I'm a clinical cardiologist from Ottawa. And it is my great pleasure today to introduce our next speaker, Dr. Wes Oczkowski, who will be talking to us about the 3-minute neurological exam, Demystified. So just first, before I present his bio, I just want to remind everyone in the room that the talk will only be screened it's shown on this screen. So if you want to move to this part of the ballroom, that'd be great. So first, Dr. Oczkowski is a professor in the Department of Medicine at McMaster University and stroke neurologist at Hamilton Health Sciences. He is presently the medical director of the Central South Regional Stroke Program and academic head of the Division of Neurology. Dr. Oczkowski has published in the fields of cerebrovascular disease and stroke rehabilitation and is a research investigator at the Population Health Research Institute. So please join me in welcoming Dr. Oczkowski, who will kick off the afternoon of the first day of the clinical update. Thank you.
Thank you. This is going to be a little bit of a challenge. I usually don't work behind the podium. I work in front of the podium. But so ignore me if I'm up and down the stairs and doing things, and I may at one point end up there and just yelling across the room if I need to. So what I'm going to talk about is the 3-minute neurological examination. I think it's one of those things that I've been talking about for my entire career. As a junior neurologist, being invited to the Ontario College of Family Physicians to talk about the neurological examination, it's never a dull thing or something that people want to talk about. And I maybe have it right, not quite yet, but I think I've got it right in terms of what it means. I have no biases, mitigating everything. These are my learning objectives. I hope that actually after you leave here, my main objective is that you're going to log on to one of the sites and train yourself to do the NIH stroke scale. That's the objective. And you'll understand, and then you'll be comfortable and understand why, and that you, and I wish all my emergency room physicians and everybody else who's a non-neurologist would just do the NIH stroke scale and throw in some reflexes, and I'd be really happy. And I think we'd have everything taken care of in terms of the neurological examination. And I'm going to show you why, and then we're going to also we're going to do some cases, stroke cases, and the stroke cases are going to be there just to show you that, in fact, the NIH stroke scale, which people think, well, that's just a stroke scale, it's not going to work for general neurology, and I'm going to show you it works for general neurology as well. And the 3-minute neurological examination can be a 1-minute neurological examination in your office when you have a healthy patient, that you can practice that exam. So to start off with the case, a real patient I saw, a 72-year-old man, hypertension, smoker, a stroke call, dizzy, facial droop. He's in trauma room 3. I can see him sitting there. He's drooling. The ER physician said, I don't think this is for you, because he clearly had no arm or leg trouble, was alert and communicating, although he was drooling and having trouble with his saliva. That was the only thing that was obvious. But I said, well, let me see him. I'm here. Why don't I examine him? And I did an NIH stroke exam on him, and let's do an exam on him. And this is what I mean I would have done. And let's see how this works. This is on YouTube, not secured.
So how are you feeling today?
Fine, thank you.
You having any pain?
No pain.
Any discomfort anywhere?
None at all.
I'd like you to tell me how old you are.
59.
Very good.
59 years old.
And what month is it right now?
February.
Very good. Close your eyes and open, and take your hand and make a fist and open. Terrific. I want you to look at my finger and follow it with your eyes. There you go. How many fingers you see?
1, 2, 5, 1,
Perfect. Now can you cover your left eye with that same hand? That's great.
1, 2, 5, 1.
Very good. Show me your teeth. Good. Relax. Close your eyes real tight. Tighter, tighter, tighter. Great. Now open your eyes and raise your eyebrows up. That's terrific. 1, 2, 3. Okay, and you can move it proximally. Very good. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's perfect. 1, 2, 3, 4, 5. Very good. 1, 2, 3, 4, 5. Very good. Take your right hand and with your index finger, touch my finger, and now your nose. All the way. And now my finger. And now your nose. And now my finger. That's terrific. So relax on that side. Let's see if you can touch my finger with your thumb on this side. If you can get it over towards me. Okay. Straight down, all the way. And now come back up. That's terrific. Now let's switch legs, and I'll help you a little bit. Let's get this one as high as we can to start with. Right about there, if we can, and then slide it down, and slide it back up. Okay, good. So we'll start here, right,
Right.
left. Which is sharper, or are they the same?
Right is sharp.
Right is sharp. Okay. Do you feel the left at all?
No.
You don't feel it at all?
Not at all.
Okay. Now, I'm going to touch your left or your right arm. Which one is sharper?
The right is sharper.
Okay. And do you feel me touching you on the left at all?
No, I do not.
Not at all. Same thing on the legs now. I'm going to touch you on the left or the right. Can you
Right
feel?
is sharp.
Okay. Do you feel the left at all?
No.
Very good. Now I want you to take this card, put it where you can see it, and tell me what you see going on in there.
There's a woman washing dishes and the sink's overflowing, and the kid's got his hand in the proverbial cookie jar. And the boy does, and the girl wants some cookies.
Tell me what this is right there.
Chair,
And this right here?
key, glove, cactus, grass, feather.
Very good. And what's this thing?
It's a hammock.
Very good. All right. I want you to read these sentences to me, if you would.
You know how? Down to earth. I got home from work, near the table in the dining room. They heard him speak on the radio last night.
Very good.
Mama, tip top, 50-50. Thanks. Huckleberry, baseball player.
Close your eyes. Is that right, left, or both?
Right.
Right, left, or both?
Right. Right.
Okay. We'll try your hands now. Is this right, left, or both?
Right. Right. Right.
Okay. And then we'll try your legs.
Right. 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 Left knee, I think. Right. Right.
Good.
Left. Right. Left. Both. Right. Both. Both.
Very good.
sorry, that was 5 minutes he took to do that examination. I put a timer on. He took his time. That didn't take that long to do that examination, and he examined a person that had abnormalities, someone who definitely has problems doing things, and you have to tease out things and so forth. And it took literally 5 minutes to do that examination. And Dr. Linden, who's one of the first, he's from the first training programs in NIH stroke scale certification going back to 1998. And it's still on the web. And when you do your training after you finish here today, and you're going to go home and do this training, you're going to find him teaching you about doing this. I had to retrain because we do stroke trials, and you have to be good at it and do it systematically. The first exam I've done in like 20 years, I got 100%. I was so happy. I ran up and down the hall, so I got 100% in my NIH stroke training. So this patient, Bill, his NIH would look like this. And this is his, could be his written out neurological examination in the chart. All we would have in the chart is what he had abnormal, and not what I see when I was on the neurology clinical teaching unit with my residents this past week. And you look in the record and you see, cranial nerves, 1, 2, 3, face, this, that, tongue, arm strength, 3+ motor scale, this and that, sensory, and it goes on and on and on. And if they would just, at least part of that, write out just the NIH stroke scale. So if the resident said to me, so I'd say, so what'd you find on your examination? Well, actually, I found the NIH was 0, and the reflexes, gait, and distal sensation and tone were all normal. And I would know exactly what they did. Not trying to say, well, did you do visual fields, and what were the Babinskis like, and what was going on? So part of the problem is that we have all these different things that we do. Who has NIH stroke scale training here? Oh, okay. Not too many. That's okay. And it is heart and stroke, but let me tell you how it may work. So there's this person's examination, and that examination in the bars is the NIH stroke scale score. Down at the bottom is a few things I'm going to talk about. And just because you stick with a score doesn't mean you can't add something. And so I've added those things on the right side, sort of in the margin, the ptosis, the meiosis, and the weakness of the left palate, which isn't part of the NIH. But if, those of you who may be neurologists, anybody neurologist in the audience, would sort of put this together and say, I know what that is, what's going on. So the one thing about, if you're seeing somebody in the office or definitely in the hospital with a focal motor or sensory problem, I'm going to talk about some basics or do some cases. A focal motor or sensory presentation, on my clinical teaching unit last week, it's either going to be a stroke or a seizure in the hospital or something else. And it's the vast majority is going to be a stroke or seizure or something else. And where do you see the brain tumor in there? If anybody has a neurological problem, they always think they have a brain tumor. I've asked every patient, they go, yeah, I'm worried about I have a brain tumor or cancer or something. It's not there because often that can be ruled out by just the scanning and the imaging, right? You do the scan and it's not there. But something that presents with a focal motor or sensory presentation is often going to be either a stroke or a seizure-like problem. And you could throw in another little box. Somebody who's much younger, it could be migraine with focal deficits. So migraine, seizure, stroke. Those are like the big focal presentations, motor or sensory. So when you talk about, anybody do stroke work, like on a regular basis? Some people. Do you do ER work on a regular basis? So when they present when somebody presents in the emergency room and they have a focal motor sensory deficit, when they have chest pain, if somebody has chest pain and it's a cardiological problem, the cardiologist get an EKG. You get an EKG because you're measuring the damage to the heart. And in the neurology world, not just the stroke world, our EKG for neurological problems is the measurable deficits on the examination. That's what that is. So the problems that the brain is having or the nervous system, that's the EKG. A little bit more complex than running a piece of paper through a machine that can often interpret it. So that's the EKG. What about, they have also an easy life. They have troponins. Do we have a troponin? We do. It's vascular imaging. Just the last little while, and the one thing that you're going to see throughout the whole provincial system of neurology and stroke and that is that you're going to see more and more stroke neurology, and in bigger centers for sure, stroke neurologists being distinct from general neurologists. The stroke activity has ramped up tremendously with all kinds of advances that have happened. We have 8 active stroke neurologists in Hamilton in the regional center at one hospital, and we're short for the amount of business that we're doing in terms of hospital and ER and assessment and evaluation. And every patient that we see, we ran into a panic situation at the Hamilton General because we're replacing our 2 antiquated scanners, and there was a risk that when they were replacing one of the scanners that the other scanner may go down. In which case, stroke neurology, neurosurgery, and trauma, which only exists in one big site in most regional centers, cannot function. It's like we can't get troponins done or anything else, or cardiac caths or anything, to know what's going on. We just don't know what's going on unless we can image the brain. It's like a whole different world. We can examine the patient, we can make guesses. Is it stroke, not stroke, mass lesion, subdural, tumor, whatever. But unless you look in the brain, you can't be sure. You don't know what it is. So this is the 3-minute neurological examination. That's the NIH stroke scale. And I've sent out sort of a review of a neurological examination that I'm trying to put together, a standard exam that everybody in this room, hopefully before I retire, will be doing. And we'll be all talking the same language. And this examination will sort of look like this. This is a neurological examination. And at one point, before I understood what I wanted to do with this, it used to be called a screening neurological examination. And I took that out. Screening has specific connotations. It means you have a sensitivity and a specificity. You know, you're going to find stuff, you're not going to find stuff. So somebody comes into your office, or you see them with a potential neurological problem, and you're going to do a neurological examination. Who's worried that they're going to miss something because their exam is rusty? Who's worried? Come on, be honest. Be honest. Almost everybody. I think that's the worry, okay? You're worried because you haven't done a complete, full neurological examination forever. You can't remember the one you did in medical school. You don't do one regularly. But here's one. And in that examination, so what's not darkened is the NIH stroke scale. And what's darkened is what my colleagues, and for other reasons we'll talk about, I put in to make this what I think is a complete neurological examination that even my neurology colleagues, who I've vetted this across, would say, oh, this is good enough. I think this is an exam I could do, like a complete examination, a neurological examination. There aren't, and you say, well, where's this, and where's that, and where's the frontal release signs, and how about the peritonia stuff, or, you know, the this and that. Well, all sorts of things that I can do, that I need to do, but you don't have to do. But please do this. I'm going to try to convince you today, and with some practice, that if we can design something like this, if I can get my act together and design something like this, we can be all doing the right thing. So these are those pictures that Dr. Linden was showing, and it's a marvelous. So one of the challenges is that who's can do the neurological examination in their sleep? I can. Who can take the stethoscope and not try to figure out which way it goes into the ears? Everybody. Who can take the stethoscope and know which side of the chest to put it on? And who can take the stethoscope and know where to listen for the heart sounds? Okay. Why can't you do that with a neurological examination? It's a tool. The problem is it's got all these pieces, and you don't do it routinely. You get it? That's the problem. That's the problem. And so, for example, if you didn't have to, let's say we could all of a sudden just give you something really easy, and you could, that's what everybody wants, is something like, give me something really easy, like 3 things. Actually, I will give you something really easy. 4 things. But this is, so that, one of the things is, I mean, it'd be nice if, so I can sit down, and I can do an examination with a patient, and I'm not, because of practice, deliberate practice, I'm not thinking about what I'm supposed to do next, or how to do this test, or how to hold this hammer, or how to strike this reflex. I'm wondering about, how does this work? And what am I seeing? That's where I'm at, not figuring out how to use the tool. So this is like a very powerful tool. You think that's just a picture. Well, in that picture, if I show a patient that picture, and I often start with this picture, like he gave it at the end, I would give it at the beginning, because you can then hear how the person talks, you can see how they think, you can see if they see and visualize what's in the picture, they can tell you if they appreciate the right and left side of the world, do they have any neglect or inattention, do they have any agnosia? A gentleman with a large non-dominant stroke I said to him, so what do you see here? Took his finger and he draws and see, I see this line. And what do you see here? Well, I see this circle. And what do you see here? There's another line there. And what do you see here? Or there's a line here. He couldn't see the picture. His brain couldn't see the picture, but he could see the lines. He couldn't visualize the 3-dimensional picture, something our brain learns how to do. So you can listen to them talk, and you can figure out how the brain is thinking, and you can make them sort of analyze things. And then this kind of thing, and sort of a clever patient said, you know how, down to earth. She said, those aren't sentences. And I said, you're right, they're not sentences. They're designed specifically like this because I just want you to read them and not say automatic things. So you have to specifically read them. And some people, famous neurologists in aphasia would say, if you can read through this list, you don't have aphasia. And if you can name these pictures, you can read through that list, you're not aphasic. So who has another aphasia test they do at the bedside? There's one. Very straightforward. Because, the 3 things that get mixed up with aphasia, aphasia, delirium, dementia. Like, is it aphasia or is it delirium, is it dementia? Is the person confused or are they aphasic? Who cares? Well, delirium is a relapsing, remitting, something associated underlying problem thing. Dementia is a progressive, diffuse neurological disorder. And aphasia tells you there's something wrong with most people's left hemisphere. There's something there. It's very, very different, very important. So this is the complete, I think, neurological examination. And what does it go through? I'm just going to run through this quickly. It has a mental status part to it. What do you mean it has a mental status part? I didn't see any mental status examination in that what he did. He asked the person how old they were and what month it was. There's a trial done looking at orientation to time in patients on the ward who have delirium and or dementia, and orientation to time. If they can't tell you what year it is, what month it is, what day it is, there's an 80% chance, sensitivity, specificity, that they have either delirium or dementia. Hospitalized patients. If you just ask them, what month is it, what year is it, what day is it? If they get it wrong, there's something wrong with them. Micro mini mental status exam, which is even smaller than the MOCA. The MOCA is another tool that you need. You guys do MOCA, some people all the time. And the MOCA is a marvelous exam. I can give a whole another talk on the MOCA and what to do with it, like how to interpret it in a neurological way, not just the score at the bottom for the ministry and funding for NIHSS. But the micro-mini exam is in this exam. The visual spatial stuff and the dominant thing is in the exam. The language testing is in the exam that we just did. The visual fields, who does it with the finger counting? Or who does the come from the edge kind of thing? The finger counting, I think, is much easier, and much quicker, and much better. If you really, again, well, it's my opinion. No, not my opinion. If you want to find visual field defects, another study done looking at mapping out visual field defects at bedside versus official perimetry. If you really want to know about a visual field loss and a defect, you have to do perimetry. You can't be better than that. So if you think there's a visual field loss, you have to do perimetry. I threw this in. It's not in the exam. That's the pupillary responses, the extraocular movements. And I challenged my residents to say, if you have normal horizontal movement, there's nothing wrong with the eyes, even if you don't do the H. It checks for this, the NIH. The NIH checks for that. The NIH does check the palate and the tongue because you're looking for dysarthria. So indirectly it looks at that, but in the medical school training, and open your mouth, look at the palate, stick the tongue out. I don't know how many times somebody will say, everything's okay, but the tongue goes to the left. And I would say, I don't care. Find me something else beside a crooked tongue, because it's very, very non-specific. It can't tell you much. The exam shows you the motor systems. It shows you the sensory systems. It shows you you got to add the reflex arc, and I'll show you why. It checks coordination. It doesn't do gait, and you should get the person up and walk them. So the thing is, this is all just introduction. We're going to do some practice. People want the exam. Who wants the exam? Smiling. They all want the exam. And the question is, the exam for what? So do you have the cardiology exam that you do? We'll keep it Heart&Stroke. Do you have the cardiology exam too? Everybody do the standardized cardiological assessment? Everybody's looking at me kind of funny. Is there such a thing? I don't think there is. There should be one. There should be one. I remember a cardiologist as an intern, I remember way back Dr. Eugene Biagioni standing over me, and I'm clerking somebody in for a cardiac cath, and he said to me, what about the femoral pulses and the distal pulses and this and that? And I'm listening to him, and I'm thinking back like 30 years later, I'm thinking, he had a standardized cardiological examination that he did all the time on these patients. He didn't have to sort of put something together every time he saw somebody. And so I think one of the things, do you put something together every time you do a cardiovascular exam? You should probably have a standard exam, right? And the one thing about that, there are three types of examinations. There isn't the exam. There are three types in every medical disorder, but much more obvious in the neurology world, that there are three types. But there are three types in every medical disorder. There's a diagnostic examination. So a diagnostic examination, so in neurology, it identifies the neuroanatomical diagnosis, where the problem is, and helps possibly identify what the problem is. So you don't get brain tumors in a peripheral nerve. So if the peripheral nerve is causing weakness, it's not a brain tumor, right? So that's the thing about, so when you think of a neurological exam, who thinks of trying to figure out where the problem is? Isn't that what you were taught? Like, you got to figure out where the lesion is. So who gets nervous about doing that? Not a neurologist, that's their job. But everybody else does. Like, where is the lesion? Now, do you get nervous about doing that for somebody who has a cardiorespiratory problem? Doing this. You do this. You don't know you do this. So what? Somebody comes in and they have middle-aged kind of individual, and they come in with shortness of breath. No known past history of any kind. And you're going to do an examination. Take a history, you're going to do an examination. I'll talk about the history. You do an examination, and the examination, what are you doing? You're trying to figure out why they're short of breath. So is the problem from the lungs? Is the problem from the heart? Is the problem from the etiology being pneumonia or pulmonary embolism or costochondritis with pain in the chest or a pneumothorax? There are multiple different reasons why the problem person can be short of breath. So your examination is going to be checking out, interrogating the cardiovascular system, the respiratory system, the lungs, looking at the legs, checking the blood pressure, the pulse, the JVD, because you want to know why they're short of breath. So you're doing a diagnostic cardiorespiratory examination to figure out where the problem is coming from. Now it's all centered around the chest. That's the one thing. Every other medical system has one advantage over neurology. Where the problem is usually where you examine. Not in neurology. That's the problem. So this is the what am I here? So this is my diagnostic examination. I think you've seen that before. Now the other thing is there's a once over, and I'll not use the word screening. There's another kind of examination, a screening exam that everybody does for patients that you see all the time. OHIP mandates you examine people, unless you're doing psychiatry. You don't have to do a physical examination. But if you're doing clinical medicine, part of what there is there has to be a physical examination component to a clinical encounter, to some degree, right? But that's not why we do things. OHIP can do whatever they want, as long as they pay us. But you need to do an examination. So somebody comes in, and so I said to the residents who are in medicine, I said, you'll be seeing people tonight, admitting them with heart failure, but are you going to be doing a neurological exam on them? And they said, yeah, of course I am, because somebody may ask me tomorrow what the neural exam showed, if it was okay or not. So they have to do some kind of neurological exam. They have to do something with this patient, and they have to do sort of a once-over kind of thing that they can do. But, so who's the patient? It's a patient where the pre-test probability that you're going to find something wrong is very low. So you don't expect anything wrong, but you want to do an exam. Correct? You have to do something. So somebody comes in with headache, new headache, it would be probably CMPA territory if you didn't examine them. I don't want to scare anybody. I get nervous from the CMPA. I work with the CMPA. The last couple of consult cases of stroke things. I do very little of that. But you have to do some kind of exam. So have a standard exam in your pocket to pull out and do it. And what could that be? Well, it could be this. Looks familiar. And then you have, your poor patient comes in, or you're in the hospital doing ER work or something or other, or your patient comes in with known heart failure. Go back to heart. Known heart failure, ischemic cardiomyopathy, known heart failure, just discharged from hospital, shows up in your office, and they say, well, my breathing's not as good as I think it was when I was discharged from the hospital. So are you going to examine them? That's their story. No new chest pain. Are you going to examine them? Of course. What are you going to examine? You're going to try to figure out why they're short of breath? No, not really. You know why they're short of breath, because they have ischemic cardiomyopathy, and that's the heart failure. So you're not going to try to figure out why that shortness of breath is from that. You just want to know if the heart failure is worse or not. Are you going to be just doing a quick cardiological screen on them? No, because they have probable abnormalities. So what kind of exam are you going to do in that heart failure patient? You're going to do the appropriate evaluation for measuring and then subsequently monitoring if their heart failure is the same, better, or worse. So you're going to measure their blood pressure. Is it high enough or too low? Are they too dried out? Is their heart rate, their atrial fib under control or not, or under control? You're going to see if their JVD is up or down. Are their lungs clear or not? Is there a third or heart sound or fourth heart sound? Is there edema, and how big is the edema? And then you measure that, and you're going to get them on the scale and weigh them. And then when you have all that in your chart, they come back in a week and they say, well, we'll double up your Lasix to 40 BID. Come back next week and at home measure your weight, and and what do? You go through the same stuff. So what you're doing is you're going to measure and monitor. And in neurology, a lot of stuff we know what people have. So they come into our clinics, they have known Parkinson's disease or stroke disease or multiple sclerosis or other problems. And what you want to do is measure and monitor. You could use this. Again. So the thing about what I want to drive home is I think we need, and I think in the other medical subspecialties too, you need some kind of exam that everybody should do the same way. You could call your cardiologist, they would call and you said, I think your patient is discharged, they're having trouble. And they would say, so what did you find? Well, on the cardiac valve thing, this is what I found. They go, oh, okay, got it. Not like, what's their edema like? Oh, let me check. What's their weight? Nurse, could you, weigh them? True? True. Or neurologically, they say, well, so do they have visual field trouble? Hold on a second. Or the reflexes. Oh, okay, they didn't have a hammer. So the thing about this neurological examination, this is I think the problem is that one is I think we're all trained in sort of a different way. We were trained that you had to use it to figure stuff out all the time. That was the only thing it was good for. And everybody I think was taught a different examination. There isn't a standard written out overall exam. Depends what medical school you went to, who your mentors were. And we don't speak the same language that way. Now, just to make people, to reassure people, because I'm telling you, I'm going to try to convince you that this is like a complete neurological exam, and if people are saying, I can't walk out of here and make myself into a fool next time I talk to a neurologist, that I do something like this, because they're going to say, where'd you get that? What are you talking about? So let me just reassure you. This is from neurological patients. And this is reassuring. For those of us in practice, this is why you need to see lots of patients, 10,000 patients. I've seen, because I have I think I'm to like 35 or 40,000 new patients in my career. I know I don't look that old. But I know that from sort of like initially starting my health medical records, it starts with patient number 1. And when I sort of switched over multiple things, I sort of guesstimate I'm in the 30,000 range of new patients. If anybody came back always says the same number, right? So 30,000 new patients that follow us. And those of us in practice, in clinical practice, you have that, right? The thing about that is that if somebody calls me, or the resident says, we're going to go see somebody on the 5th floor with this or that, 80% of the time, if I'm any good at my business and I get the chief complaint, I'll know what I'm probably going to be dealing with. And those of us in practice for a while, that you get a call from Mrs. Jones and it's on the phone, and you probably know what it is, right? Most of the time, 80% of the time. If you add a little bit of the history to it, even in neurology, this is from neurology, if you add a little bit of the history to it, 95% of the time almost, I'm done. I know where this problem is, what this problem is, or what I need to do next. And the rest of it, all the diagnostic testing and everything, is supplementary. It's part of the examination. So that's one thing. So, don't be afraid of the exam because the money's in the history. Important thing to remember. Don't get nervous. Then the other part is too. So I'm a neurologist, and I do this over and over again, and I've been trained to do a neurological examination. There are many things I forgot how to do over time. But how good is a neurological examination done by a neurologist? You take 45 people with known neurological disorders by imaging, lesions in the brain up here, who don't look like they're paralyzed or have obvious things out here. Like, can you have that? Anybody seen a patient of theirs who, said, I'm at the, at a clinic or a cancer clinic or somewhere other, and I have a brain lesion, and they sort of walk in and you talk to them and you look at them and they're kind of normal? Yeah, the brain's a big place. They're only this sort of motor strip and the stuff that goes out that you actually see. There's a whole pile of territory, 100 billion neurons, 400 trillion connections, a lot of malleability, a lot of plasticity. It's a difficult thing to always to interrogate. Take 45 people who walk in looking normal. The neurologists, 6 neurologists, aren't allowed to ask them a chief complaint or take a history. Put them on the examining table. They get to do a 40-point neurological exam. Some of the things I had to look up. And in that 40-point neurological exam, I'm joking. In that 40-point neurological exam, there was clock drawing was in that, and all the other things you could ever think about for a neurological exam. How sensitive is a 40-point neurological exam in people who otherwise look normal, walk into your examining room, done by a neurologist? Mentor of mine, used to say, save that CAT scan, just do a good neuro exam. How sensitive is it? Done by a neurologist. 60%. Only 60%. 50% of that, so this is the micro-mini neurological exam. Micro-mini. Finger rolling, forearm rolling, assessment of power, rapid alternating movements, pronator drift, detects 50 of that 60%. So if somebody walked in and took a history and you wanted to just do a quick screening exam, I would hope you do the rest of the other one, learn thing. But this is what you could do. And this would give you, somebody say, that's all you did? Here's the paper. Here's the evidence. So what does this mean? So you get them to do this, finger rolling, arm rolling, a dynamic motor test, assessment of power, this is all in the upper limbs, alternating movements, and drift. And if you don't find anything, then you probably won't find anything on doing completely a complex kind of thing. Amazing. Now, I wouldn't recommend that because I'll show you why for another reason. But this, as a micro-mini screening, sort of once-over kind of thing, this would give you most of it. Isn't that, you're going to take this home and do this now. Yeah. So, we get back to so there are many ways of doing things. So it's talking about the diagnostic neurological exam. Let me stop there. Anybody have questions about what I just talked about? So I'm going to go on to actually showing you to hopefully convince you that maybe we could do an NIH, learn that, and do your neuro exam, because it'll give you all this tremendous information. And when you call me, you can say the NIH was 0, and I'll say, great. I'm glad you did that because I don't ask anything else. Any questions about that? Any of that? Yes. So what this so if you add all the other 36 elements of a detailed neurological examination, and an otherwise normal-looking individual who came into your office, you would only add 10% more sensitivity to pick up something. And if you just did this, you get most of it. Now, this doesn't, so what this is saying is, in fact, if the chief complaint makes you worried that your patient has a brain tumor, what this says is that the chief complaint says, I'm worried this person may have a mass lesion or a brain tumor. It doesn't matter what you find on the examination, no matter how good you are, they need to be referred and they need to be imaged. That's what this says. It says that the sensitivity of a detailed neurological examination in an otherwise normal-looking individual who walks in is not that high. Normal people examine normal, so the specificity is very high. So if somebody is normally do a neuro exam, a detailed neuro exam, they usually examine normal. But you can, so the take-home message, I'm glad you asked the question. The take-home message is that if you're going to do anything, you have to remember that the chief complaint is most important. The rest of the history is secondly important. And even if your neurological examination is normal, no matter how good you are at it, if the chief complaint and the presenting illness say to you there's something wrong here, there still could be something wrong here. And don't reassure yourself that I wish I only knew how to do a better neuro exam, because it's not even going to help me. That's the point. I think kind of reassuring. I think it's reassuring, not distressing. I think it's reassuring, because we don't have to be that sort of aggressive doing the exam. So we're going to spend a little bit of time. Let me just, I don't have it upset in a certain way. So we're going to take a little bit of time about a diagnostic neurological examination. This is the part that I do as a neurologist, and you can play with as well. Part of my job is to teamwork with you and the community, the hospitals. I'm the sort of the neurological side, and my job is to be really good at figuring out where problems are in the nervous system. And I'll tell you why we need to know this, why I need to know this, why we need to work together for this. So where is the lesion? What is the lesion? So when we do a neurological examination, what am I doing? It's the only examination, medical examination like this. It's the only examination that's reliant on left-right comparisons, except rheumatology, you can have left knee, right knee. It's the examination that relies on a top-down evaluation. And it's the only examination that really is about me and my patient. There's all this kind of interaction back and forth. What do you feel? Does that feel the same? Look at me. Look over there. How many fingers? You're comparing your fingers to their fingers. Take this piece of paper and describe, and you tell them what to do, and they have to draw it. Most of the other examinations are, does it hurt? That's it. No, you can have to say breathe. No, it's true. This exam is a game. It's like a game. You can play a game. And you have to know the tools to play this game. But it's like this, top, down, left, right, and patient examiner. At the end of the day, and my senior neurology residents who are working for their exams are going, oh, is that, no, don't tell this to everybody else, because we have to know so much more. Yeah, you have to know so much more until you pass your exam, and then you can play with this. All I really need to know when I'm examining a patient is the problem in the hemispheres, the brainstem, the spine, the nerve, the muscle, or the neuromuscular junction? That's the only pragmatically, the only neuroanatomical localization I need to know. That anybody needs to know, really. But, so, that should be pretty straightforward. I mean, that should be pretty straightforward. The problem is that the nervous system is a distributed system. It's the only system that's distributed. I went home one day, I went up to the bedroom, and my iPad Wi-Fi went off. Oh, like daytime. And I sort of thought, oh, what's funny here? And I look over, there's a router on the thing, and the router light's not on. I thought, oh, the plug must have gone. And I sort of looked down, and no, it's plugged in. That's plugged in. Oh, the lamp's not working either. Old house, must be the circuit, maybe the circuit breaker's gone. So I went downstairs, and, oh, the kitchen light's not on either. Oh, the whole thing maybe is gone. So I went down to the fuse boxes. They're all up and they're okay. That's fine. Major power's on. I go outside, and it's like deathly quiet in the summer, like heat. All the air conditioners are off. Everybody's house. It's the main power's gone. So it's like the foot's weak. Where's that coming from? And weakness. And so the common presentation, 80% of the time when somebody presents with stroke trouble, for sure, this is known from the literature, 80% of the time it's going to be a motor sensory presentation. Numbness or weakness somewhere. And in neurological problems, the things that people present to you, they come to your office, they don't come to your office with, funny, they come to you when the arm is weak or the foot is weak or often they come with pain. And if there's pain, they definitely come to your office. But it's a motor sensory presentation. And the problem is, so my leg's kind of weak, it gives out on me. So where's that coming from? Well, maybe it's their bad hip. Maybe it's not even neurological, it's rheumatological, and their knee is kind of giving way. Maybe it's the nerve going into the leg. Maybe it's a problem in the plexus before it goes to the nerve. Maybe it's the nerves out of the back. Maybe it's a spinal problem. Maybe it's a brainstem problem. Maybe it's a cortical subcortical problem on the other side. And it can all show the same thing as weakness in the leg. See the problem? This is why we do that, trying to figure out where it is. Unfortunately, a lot of people present with leg weakness. You probably would still do that. They may have a spinal problem, but they still get a head scan done. It shows nothing. It's all normal, right? It's all normal. It's not where the problem is. So that's the problem. Weakness is a poor localizer. And then the last sort of back to medical school kind of point I'm going to talk about is this. Upper versus lower motor neuron. Oh, when's the last time you heard that? Long time ago. So what does that mean? And this is a kind of an important kind of thing. And so we saw a man on the ward with leg weakness, and all I wanted to do was to before I did anything with him, when I examined him, chief complaint in the history, very suspicious for a spinal cord problem from the chief complaint and the history. We're not leaving him until we figure out what's going on. And the one thing I wanted to do is just jump at him and not do a complete exam, but just figure out if is it upper or lower motor neuron in his legs. Is he spastic with upgoing toes and hyperreflexia, or is he flaccid without downgoing toes? Because one of the things is if I can tell me like what it is it upper or lower, then I can forget about brain, brainstem, spinal cord. I can forget about peripheral nerve, muscle, neuromuscular junction. So it's the one only other tool that I think is like really useful. And for stroke, so those of us in the stroke world, it is the stroke and heart meeting. I'm going to keep saying that. The stroke and heart meeting. It was only about 30 years ago or so that Henry Barnett, one of the father of stroke neurology in Canada, actually came to the meeting in Toronto and said, look, we got to add stroke to this heart stuff. So it wasn't always heart and stroke. It was at some point just heart. And in stroke world, it's really about, I'm trying to figure out, somebody comes in, is it brain, brainstem, because that's the only place you're going to get strokes, or is it the rest of it, which is not stroke, so when I'm seeing somebody. So examination of somebody with a focal weakness, and this is the underlying thing that you see a neurologist do and that we're doing. This is what we're doing. And I don't think necessarily you have to do this, but if you do the things we're going to go through in these cases, you're going to do this for me, and I can figure out with you what's happening even before I see the patient. I'm trying to figure out, is it in the brain, brainstem, spine, nerve, muscle, neuromuscular junction? Is it myasthenia gravis with weakness? Is it a myopathy? Is there a spinal cord compression? Is this a brainstem syndrome I have to get an MRI for? Or is this something in the hemisphere that I can get a CT scan and figure out? And it's all about the next test, right? It's about the imaging, right? You got to look inside. The pattern of weakness, we'll talk about that. Talk about pathognomonic signs, and is it upper or lower motor neuron, and we've talked about that. Okay. So here's case one. Any questions about that stuff? Okay. Roger, typical 57-year-old got atrial fibrillation, presented with sudden left-sided weakness. Vascular risk factors. Here's his exam. He has difficulty looking over to the left side. That's the one for the best gaze. He's got a hemianopsia, that's the 2. He has he has a significant weakness to the lower side of the face on the left. He has complete paralysis of the arm and leg on the left. That's an 8. He's got dense sensory loss like the guy we saw in the video. That's a 2. He's got extension and inattention. He doesn't even aware that he's got a weakness, and he's always paying attention to the right side. That's how you mark this down. And you can add it up together, and there's a high number there. And the high number says lots of problems. So the one thing the number tells you is about the lots of problems. But this is the neuro exam. Instead of writing down this, that, they can just write these numbers. So where's the lesion? We're going to play this game. Brain. We'll do hands up, hands down. Brain. Brainstem. I'm making it easy. Other. The whole rest of the nervous system. Other. So most people thought brain. And absolutely, because I remember walking into a room, seeing a lady, she was lying on the side, she looked at me, I said hello, and looking at her eyes, and just sort of seeing her, I said, oh, she's got, this brainstem syndrome. The residents are all like, because she had a pathognomonic sign. How much time do I have left? Oh, fantastic, okay. So he has pathognomonic signs. Pathognomonic is Greek. Pathos and no meaning this. It can only be this. It can only be this. And one of the things that neurologists look for, and sometimes you think, boy, they're wizards. And sometimes they don't, and I think many of my colleagues don't know this. What they do, like they're not sort of aware, but they're looking for these things. So this guy, regardless of what else he has on the examination, he's got neglect and visual field loss, and the only place in the entire body and brain and nervous system you can have those things from is in this guy is in the right hemisphere. Easy, like really easy. And that exam shows you that. There's a scan. He's got this evolving infarction in the right hemisphere. So even before you did the scan, you'd know what to ask your radiologist where to scan. Scan the brain for me, just a plain CT, because I'm sure the problem's right hemisphere. And he was a hyperacute stroke. This scan may look like this side, like completely normal. So you do the scan, it's completely normal. And then they, you know, am I still right? Absolutely. But there's no early ischemia yet. It'll be normal. The bruise hasn't yet developed. So it's useful to know the exam. Maria, these are people I've seen, 66, found at home on the floor, unable to talk, and with right-sided weakness. There's her exam. So the LOC things are alert and awake. Is she alert and awake? She was. The B is close your eyes. No, the B is how old are you? What month is it? C is close your eyes, open your eyes, make a fist. And she couldn't do any of that. She couldn't tell her name, didn't do anything. She had a visual field loss on the right this time. She had a facial palsy, complete lower motor neuron looking like facial palsy on the right. And everybody sort of heads went up, thinking, lower motor neuron facial palsy. Is that a Bell's palsy? But a Bell's palsy with a hemiplegia, not a Bell's palsy. That's a joke. Motor arm and leg, densely weak, H. Some sensory loss on the right, the pinprick. And read the card, show me the things. She couldn't do that. She was mute. Couldn't understand, couldn't that. She's aphasic. Where's the lesion? I'm not even going to ask. If anybody says anything else besides brain, they weren't paying attention the last 3 minutes. Other pathognomonic signs. Aphasia. So if somebody's aphasic, it's in the brain. Like, what else do you need to know? You have a visual field loss. What else do you need to know? The other stuff is all kind of like gravy for localization, but it does tell you about potentially the size of things and localize and size. And here's her scan. Large cerebral infarction. We're going to get interesting. This is, you think it's too easy. 85-year-old, found on the floor, decreased level of consciousness, slurred speech, vomiting, right arm weakness. Somebody seen something like this? Yeah. You know, if you do work in the ER, you see this. Nobody saw what happened. They found her. Here's her exam. She's drowsy. That's where she loses the 1 point. 0, 0, 0, 0, 0. Oh, okay. Limb ataxia. Arm and leg are ataxic on the right side. Then you go through the test. 0, 0, 0, 0, 0. Oh. The left side wasn't ataxic. The right side was ataxic. That's the 2 points. Brain, brainstem, other. Now, let me just paraphrase that my brainstem includes the cerebellum. Okay? The little brain. That's what cerebellum is, the little brain. My brainstem is this brainstem cerebellar. That's in posterior fossa, all part of the same circulation, the same location. The tracks are intermingled. So, what are you going to say? Brainstem, 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 brainstem. Limb ataxia. Pathognomonic sign. Unilateral limb ataxia, one limb and that, only place it can be. Brainstem, cerebellar connections. That's the only place. She had a right cerebellar hemorrhage. The nausea, the vomiting, you know, that kind of thing. With that. You knew where to look. 91-year-old woman presented with inability to speak. Chad's one major flutter. Here's her examination. Sort of neat though. I mean, the exam is always the same. It's like, you know, it gets kind of comfortable because it's always in the same chart, in the same order. You know what I mean? It's like the same way, same thing. And all you're interested in now is what the problems are, not what's normal, because you know what the normal should be. See what, that's like the cardiologist should do this too, right? Drowsy, a facial palsy on the right, so a droopy face for sure on the right, lower part. A lot of difficulty expressing yourself, but not completely mute. Brainstem. It's language, right? Brain. Aphasia. Frontal infarct. Now you notice, now how was this different from the other case? The difference was, remember that other case we saw, the person with the aphasia, the global aphasia? They had all kinds of other things wrong too, so that when you look at all the total points and things, the one thing that you can also do then when you have this kind of numbers, and you have all these numbers, you can sort of see about the size of stuff. So so as neurologists, I'm examining all these abnormalities, all these circuits are abnormal. It also gives us sort of an idea of size of impairment. Easy. Wayne, hiking with his wife, he's actually a former neighbor. Dizziness, lost balance, double vision. Oh, double vision, left weakness. Now we're getting kind of nervous. These are nervous stroke kind of things. If person, I think they have a stroke, they have double vision. Yes, I mean, I've seen 2 of those this week. So let's do an exam. Don't get nervous. Don't get worried. Best gaze, he's got definitely disconjugate gaze. Doesn't really matter if you can define it. It's not an I&O, it's not this or that or whatever. It's just got disconjugate gaze. You've never had it before. He's got some facial palsy. He's got some arm and leg weakness. He's got some dysarthria. Where's the lesion? Brainstem. Some CPAP would be. Brainstem. What do you think? Brain? No, a little bit. Well, so I only came up with this recently. So the thing about, so what's the brainstem got? When you're examining the brainstem, you're examining what? You're examining the cranial nerves, right? Not visual, not one and not 2, but 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 are all the cranial nerves that come off the brainstem. And so if you see double vision, that doesn't always necessarily mean there's something wrong with the brainstem. You see a facial palsy over here. Doesn't necessarily mean, like, is it a Bell's palsy or is it a stroke? Who's had that growing up? Oh yeah, Bell's palsy is a stroke. So if you see a Bell's palsy and there's a contralateral motor paresis, it's not a Bell's palsy. You see double vision and there's arm and leg weakness. It's not just double vision from myasthenia gravis or some eye trouble. It has to be central. It has to be brainstem. If you see dysarthria, the palate or the tongue, dysphagia with arm and leg sensory motor symptoms, then it has to be brainstem. So that's where I came up with, if you see a cranial nerve abnormality from 3 to 12, plus a motor sensory thing in a limb, I mean, don't call it something else except a brainstem problem. It has to be. It has to be. It's pathognomonic. It has to be. A limb motor sensory sign and a cranial nerve sign together. So what he had was a midbrain infarction. Doesn't really matter where. It doesn't matter what the anatomy. This lady had coronary angiography, post-angiogram, she had a headache, and she called out saying, I can't see, I'm blind. She was in there, I remember her. They were trying to give her a lunch tray, but she couldn't see it. Post-coronary angiogram. There's her exam. And by now, you should have jumped, say, like, everything's 0, except there. She had a visual field loss. Where's her problem? Should all be really clever now. Brainstem, other. Visual fields. The optic tracts only run through the brain, right? It's brain. Visual field loss. She had an occipital infarct. Initially, it was both occipital lobes, and it became sort of one as the ischemia sort of evolved. And she had this hemianoptic field defect. This woman had triple bypass, aortic valve replacement, woke up confused with left arm weakness. I examined her, and by now you ignore all the zeros. That means it's normal. And she's got some difficulty naming stuff. That's the language part. And she's disoriented and kind of drowsy. She's disoriented. Where's the lesion? So her ultra micro mini mental status examination was abnormal. How old are you? What month is it? Where's that stuff happen? Brain. It's like our cortex, right? So that says it must be brain. So behavior, memory, attention, all those things that you're testing with the MoCA is all brain stuff. So that's the localization of that, right? Just to be complete, finish the list. Yeah.
Let's go back to the previous case. Explain the neuroanatomy for that one. So binocular blindness.
Oh, so this woman, the Lydia.
Everyone just before that.
Yeah. So initially, strokes evolve. So she started with, like, I couldn't see anything. It was vertebral, basilar, both PCAs were ischemic. And the one must have opened up and the other one didn't. So by the time you reassess her and things sort of stabilize. So the thing about stroke trouble, it's an evolving process. It's a dynamic process. It's not like our plumbing. It's a dynamic process. Clots come and go. Collateral flow comes and goes. And so she started with bilateral occipital ischemia, and it evolved to just unilateral. That's why she complained about being blind. So the anatomy is usually vertebral, basilar, posterior, cerebral. So as a clot comes up the basilar, it can break off into both pieces and to both sides. And then one of them dissolved, and the other one didn't cause the stroke. That's what we think that physiology is that. So this lady with the confusion, which ended up having these little shower of emboli after aortic bypass, right? Okay, how many minutes do I have? Okay. Let me go back to this. No, I'm gonna bypass Greg. I want to show you something else because you're thinking now I'm just showing you brain stuff, but weren't you talking about general neuro stuff? So Harry, he came in with respiratory COPD exacerbation. He was in for a couple of weeks, and they were going to discharge him home, and it's somewhere in between. He ended up having a Foley put in because he couldn't pee, but that's probably because he was in bed and he was an old gentleman. He put a prostate, but then also he couldn't actually get up and stand and walk, so he's not dischargeable. So what's going on with him? No, so we got to see him, and this is his exam. Forget the zeros and look at the motor arm and leg, and you can. So what was that motor? So when you document the NIH, you put down left or right. You put that in, like what it is, which side. You put that in. So he had arms were 0, they were normal. Both legs were 3. He could barely move them. Both legs were 3. And then I threw this little thing on the side. You don't have to stop at this exam. Your neurologist can do this part. But this would say what's going on. He had some sensory loss. He couldn't feel the pin in his legs, but he could feel it in his arms. Where's the lesion? And here it's spinal cord, yeah. And you probably knew that by the chief complaint. You were already wondering, right? So anybody that calls your office and says, I'm falling on my legs, I can't walk, my legs are giving way. One of the things you want to do is, first thing you say is, could this be a spinal kind of problem? Because those are dangerous medical, neurological emergencies. And so he has a spinal cord problem. The exam shows that. The exam shows both legs, sensory level, loss of pin here, normal pin there. Even forget that he's got a T sensory level on the thoracic spine. And what he did have, he had a spinal sensory level, and he had a spinal tumor sitting right there. The NIH exam shows you that. I still haven't done any reflexes for anybody. Notice? And you can figure stuff out. Now with Harry, you'd find that he had hyperreflexia, spasticity in the legs, and upgoing toes. So it was upper motor neuron, which would mean his legs weren't weak from nerve problems or muscle problems, and it was probably something central. That's what the reflexes now would tell you. And then this young girl, she was a respiratory technologist, 32-year-old. She was in OBS 1 bed. There are 6. Came with her parents. They live in Niagara Lake. And she was feeling like a little bit of tingling in her fingers and toes and feeling kind of weak, generally weak. And the minor bladder kind of irritability, but nothing much. And I saw her the one day and examined her. Reflexes were sort of there. You know, I'm just giving you the whole thing. But actually, but I examined her. Let's do this exam. This is her exam. She had, in fact, she actually came back within 24 hours, and within 6 hours after that was intubated in the ICU. So what did she have on examination when I saw her the second time around? I told her to come right back. So both her sides of her face were weak. Bifacial palsy. So a little bit of drooping both sides. Kind of weak. Sides of the face are weak. Motor, arm, and leg. All the limbs, she had difficulty like keeping they're all drifting. All 4 limbs are drifting down. 10 seconds after 5 seconds. She had dysarthria. She couldn't speak clearly. But no real sensory loss, no limb ataxia. She was alert, awake, you know, nothing cortical, brainstem. And I threw in the rest of the examination. This is for the complete neuro exam. And what she had was areflexia, which is like lower motor neuron, not upper motor neuron, right? So areflexia means lower motor neuron, which means what? It's not going to be brain, brainstem, and spinal cord. It's going to be either nerve, muscle, or neuromuscular junction. And in her case, what do you think? So a Guillain-Barré syndrome. And it examines as a Guillain-Barré syndrome, this examination. So where's the lesion? Hers was peripheral nerve. If her reflexes were still there, this is one of the most challenging cases that I see in the hospital. If the reflexes are still there, it could still be nerve, muscle, or neuromuscular junction. It could be a first presentation of myasthenia gravis, or first presentation of polymyositis by syndrome. You can't be sure. So pathognomonic signs, I'm just going to finish up I think here, is pathognomonic signs, absent reflexes is lower motor neuron. But there aren't any other pathognomonic signs for nerves really, not really. This was Bill at the beginning. So Bill at the beginning, just to finish up with him, he had this exam. Remember all this stuff here? Actually, you can almost ignore all that stuff there. You can tell me, where's Bill's problem? He had limb ataxia, some sensory loss, and dysarthria. And the sensory loss was actually on the right side of the face and the left side of the body. And even not knowing that part, we didn't talk about that, he's got this ataxia. Where's his problem? Brainstem. So you could have figured that out. So the pathognomonic signs, again, he had a cranial nerve abnormality with a limb sensory sign. And he had ataxia. So that's what he had. And he had a lateral medullary syndrome. Internal medicine, Royal College exam question, always kind of thing. So there aren't really any pathognomonic signs for nerve trouble. Although it's sort of clinically, somebody complains of pain, it's going to be peripheral, not central. The nervous system doesn't have pain inside it. If your patient complaining of pain in their arm with weakness, then it's probably a nerve. Muscles usually aren't painful. They'll cause pain, and myasthenia gravis, neuromuscular junction does cause pain. So pain is usually a nerve if it's out here in weakness. Muscles don't have really pathognomonic signs. If there's sensory loss, it's not muscle. Can't be. But so there's some things like, that you can't be, right? And the neuromuscular junction, like myasthenia gravis, people say, fatigability kind of trouble thing. But not everybody, you get anybody who can DP bends or tired, right? There's fatigability. But if there's sensory loss, it's not this. So there's things that if there is something there, you won't do it. So this is my, and I do this actually, my once over measuring and monitoring diagnostic neurological examination is an NIH exam with addition of reflexes, tone, distal sensation, and gait. Those 4 little things, and I can figure anything out in 99% of my patients doing that. And if you called me, you could tell me exactly what you found. There'd be no embarrassment. You could say NIH was 0. And if the neurologist on the other end said, what do you mean by NIH? The NIH stroke score. And he said, well, I don't know that. Well, you should tell him. because you're a neurologist, you need to deal with stroke patients. You need to know score. So, the take-home messages. The chief complaint, presenting illness, rely on that. And if it says one thing, and even if you don't find anything, you still follow your chief complaint. Rip-roaring headache, never had it before, the exam is normal, still could be a subarachnoid hemorrhage. You'd never, there's nothing on the exam. And then when you do that, when you see the person, why am I doing this? Is it just like, I don't think there's anything going on here, I have to do an exam? I'll do a once-over exam. Quick little thing that you do all the time. Somebody comes in with no neurological things, your patient with a stroke problem, I think I'm worse, or you're examining people on the ward or somewhere, you need to measure and monitor. And you can, depends how much interest you have, you can localize and do a thing. But I think if you gave me information and sort of a standard exam, we could work much better. So you can get online, American Stroke Association. I just did this, I got 100%. There's a test, there's a certificate. And actually it's worthwhile because I've been doing this for many years, but I thought, really, that's how you're supposed to do it. It's the same thing I did for the last 30 years. You can train yourself to do this exam. I think it's free, and or if it's $20, it's worth it. That's it. Any questions? Yes.
So many years ago, at least 25 years ago, I stumbled onto a diagnosis of profound B12 deficiency in a high school teacher who could barely walk. He was a champion cross-country skier, and it took him a long time of B12 shots, and he finally recovered. What else did I find when he stumbled into my office? I can't remember now. If that presents, pretty rare, but...
What you would have found was profound B12 deficiency. You could have found actually an interesting thing, and I could have had to help make the diagnosis, is that in fact if you did this exam, you would have said to me, I don't know what this is. He actually has, his reflexes are gone, but his toes are up, and his legs may actually be spastic. Because he's got such profound B12 that he actually has a neuropathy-myelopathy combination. So he's got some myelopathic features of the spasticity with upgoing toes, but absent reflexes because the B12 is so bad that the nerves have gone. But doing that exam, you would have told me all those things. I would have said, there are very few things like that. There's only like almost 2 things that do that. One of them, unfortunately, is motor neuron disease, and the other is B12 deficiency.
Is that called subacute
combined
degeneration of
yeah.
the cord? Is that what it was?
Yeah.
Yeah. Okay.
That's the cord part and the nerve part, right?
Took him, years to get better completely. He's fine now, but...
Any other questions? Who's going to train and do an NIH exam? Oh. It can be like your neuro exam. Like that's the exam that you do all the time, right? And you practice it with normal people. It's great. I don't stock or shares.
Interestingly, the B12 deficiency exam is the only thing I remember from my internal medicine Royal College exam. I studied it. I studied it so much. Well, thank you very much. Please join me. On behalf of the Heart&Stroke, I'd like to thank Dr. Oczkowski for an outstanding talk. I think we all feel like we're somewhat of an expert now in the 3 or maybe 5 minute exam. 3 or 5
well,
or...
In a normal person, the NIH, you can actually shortchange it, right? You can do it like really quickly. A normal person, you should run through the same routine because that's the idea. Do the same routine over and over and over again. Same thing over and over and over again. Do it again, over and over and over again. Then that way you do it in your sleep, over and over and over again. And then then in a normal person, you practice, and it takes a minute in a normal person, right? You can put both arms up instead of one. Put both legs up instead of one. Finger, nose, heel, shin. Sharp, sharp, sharp. Left, right, whatever. You're done. Like it's quick, very quick in a normal person. I mean, who would spend more than 5 minutes examining that person who had all those abnormalities that Dr. Leiden did? I think on your standard neuro exam, you probably spend more than 5 minutes there. You probably 10, 15 minutes trying to do the exam. Mm-hmm. He did 5 minutes. I timed it.
Great. Thanks again.
Okay.
Thank you very much.